to start now, do you think? Start now? Yep. Okay. Thanks everyone for coming along this morning to the SARRAH Forum, which usually would have been a conference or something similar, but we haven't had a chance to connect much with our members lately. So we felt there would be a lot of value in connecting with you this way and sharing the issues and solutions you're dealing with at the moment where you live. I'd like to start by acknowledging the traditional owners. Firstly, the owners of the custodians of Wiradjuri land where I am today. They have been here for tens and thousands of years, caring for country, caring for community, and caring for each other's health and well-being. And I don't think we can rightly go through with this meeting and discuss the kinds of things that we want to discuss without acknowledging that and the deep knowledge that the traditional owners have in helping and healing on country, as well as the Wiradjuri peoples. I would like to acknowledge the Ngunnawal people who are the traditional custodians of the lands on which the SARRAH office is located and where we do a lot of our work. So I acknowledge those peoples as well, any Aboriginal and Torres Strait Islanders who are here with us today, and also the lands on which you may be coming to us from. So about today, we have a broad-ranging discussion planned, which we know we won't get through the entirety of, but perhaps today is more of a beginning of a discussion about what allied health is doing in community at the moment, what we could do better, and what is working as well. Not to forget that. But there are continuing local and systemic issues that we're facing in allied health service provision. And while we do have some success stories, we do have a lot of shortcomings and inequities, which are often related to workforce, whether it's recruitment, retention, distribution of the workforce, or indeed clinical skills in the workforce. That's why we've invited our members here today, because we recognise your expertise in this area. We recognise that you are people who are leaders within your communities, who are leaders within your professions, and who provide services around what can sometimes be a lot of red tape and very little help from others. So we thank you for coming and sharing with us today. I think in the past couple of years, we've faced especially great challenges in the face of a global pandemic, which has even further disrupted the services which we can provide and provide effectively as allied health. And that's something that we may touch on today as well. I think that there are new models emerging. There is an increased usage of technology to deliver allied health services. There's an increased usage of co-workers, allied health assistants, therapy assistants, however you might term those colleagues, and real possibilities for providing more comprehensive and more place-based allied health supports in the future. So that's what we want to hear about from you today, how that's happening now and how you see that happening in the future, what possibilities you see for the future, whether good or bad, hopefully good. There are a lot of possibilities, I think, out there with the way that the research and clinical practice are moving. So essentially, we want to know what works for you, what doesn't work for you, and where should we be going from here. Specifically for SARRAH, that will mean informing our policy and advocacy efforts in the future. Just briefly on housekeeping, the meeting today is going to be recorded, so you can watch it afterwards, or other people can watch it afterwards on the website. It will be on the members only section of the website. There are lots of people here today, so if you could keep yourself on mute and possibly turn your video off if you're not speaking, just so we can focus on our speakers, because we'll have a few speakers soon who will be sharing about their personal experience. Please use the chat function if you'd like to make any comments, or if you have any relevant information to share with us there, and use the raise hand function if you'd like to speak. So please do jump in and ask questions in the conversation if you have something to share. With that, I will hand over now to Alan Groth, I think, to give us a little bit of a summary of the policy landscape in allied health at the moment. Thanks, Al.
Thanks, Ed. Hi, everyone. I'd also like to acknowledge the traditional custodians of the lands we're meeting on, and the breadth of our representation today would make that a great many nations, I'm sure. So in Canberra, it's a Ngunnawal and a Ngambri. Like Ed, I'd pay respects to elders past, present, and very importantly emerging. And I note our friends from IHA are also online, so they're important in developing that, and we want to be part of it. So, I mean, welcome and thank you, everyone, because this is a couple of hours that is going to be jam-packed, but it's 2 hours out of days that are really, really busy, and we really do appreciate that. And there's currently something in the 50s online. There might be 80 of you in total. As Ed mentioned, the chat function, we want to capture everything you feel like putting in. So don't be shy of throwing that in or subsequently emailing us, because there'll be a lot of commonality today, but there'll also be those issues at the fringe that only pop up in certain communities or in certain situations, and they are so often dropped in policy or not picked up. We want to capture those. Anything you want to share, we will not leave this alone. Once it's in, we'll be collating information and referring back to you. So it's part of a discussion that's a bit more ongoing, we hope. Okay, setting a landscape here. I'm not going to elaborate too much on the very obvious. We have an election coming up. It's a federal election. It's going to be tight. There's unlikely that unless we push, there's going to be a great deal in there about allied health services. There will be mention of things like the NDIS health and aged care, but the likelihood that allied health services and long-term sustainability and distribution and the sorts of things we're talking about with service capacity and workforce development probably won't get a big run in that unless we push. And that needs to be a doable, coordinated push. And I'm not picking at any particular electoral flavour here. We could lift the game across the board. And that will be really important for us, I think. So that's one context. The other context is in the background, there is a huge amount of consultation process going on. Some of them lead to things, others just muddy the water. But there are a lot of processes in NDIS, 10-year primary healthcare plans, aged care quality measures, you name it. They're out there and they all touch on the work we do. Central to our focus with here is the NDIS workforce plan, which is currently, it's been released, but it's in the process of further refinement and implementation, and that's likely to take a while. I'll just alert people to this but we'll send it out separately. There's a NDIS workforce plan briefing on the 14th of December that DSS is holding. So I'll flip that out and I'd encourage people to be part of that because we need to be part of the implementation. There are parliamentary inquiries around GPs at federal level talking about, oddly enough, GPs predominantly, and maldistribution. We've contributed to that, and we hope that most of you will as well, to talk, just to let people know that healthcare, social services isn't just about GPs, it's about the 85% of the health workforce that aren't doctors as well. As crucial as they are. Similarly, New South Wales and Queensland are running them, and I think some of the others, and these will be quite important as we get into election cycles, wherever that election is, and that Commonwealth state debate around who's paying for what and how things work. So there's the broad context. It's going to change, but there's always those themes, and those themes are going to keep coming back. What's often missing, and what I think we need to get out of today, given that there will be up to 80 people who are variously health practitioners, service providers, disability service providers, supervisors, educators, policymakers online today, and between you, there'll be decades. Each of you probably have decades, or not everyone. I don't want to insult those who don't. Of experience that predate the NDIS that probably span a couple of sectors and probably have experienced enough of the frustrations of trying to make pieces of Lego that don't quite fit your local mould work for people. That's what we've got to get into the policy, and that's what we really encourage you to do today. I haven't talked about COVID yet, and I'm not going to talk about it much, partly because I think we've heard enough for a while. But the important thing about COVID that's really starting to happen, but it's hard, is that it really shows the chinks in your system, that those problematic areas, the weaknesses, and we know that post-COVID, the difficulties in workforce shortages and service capacity that was already problematic before the NDIS was even implemented is now even worse with COVID. We're losing people from rural and remote areas, and that says a lot about where things need to be built up. So we have a universal system of healthcare, of NDIS, aged care. There's a lot of focus on compliance, there's a lot of focus on quality and guidelines, but there's not much focus when it comes to access. So the question for us across all of these things is, what does a legislative entitlement mean if you don't have the service capacity or the workforce structure to deliver it to probably 30 to 40% of your population, if not more? And that happens over years and is structurally a problem. There's that question about what does a legal entitlement mean and where is the gap? And that has to be in service structures, either funding, requirements, lack of flexibility, the incapacity to enable rural communities to work as place-based networks, to draw on their strengths, to be able to attract and retain people and to contribute to that workforce development that often sits there innately untapped in the communities we're talking about. So I think that's the sort of scene setter from my perspective. It's really about encouraging you to draw on what your experience is and really promote, not we're not hiding anything. The big issues have to be out there, otherwise how do you address them? So we shouldn't be shy in that. But the other side of this, which hopefully we'll get through the day, is there's also a hell of a lot of innovative good practice. The people who have been managing this for decades have managed to work and continue to manage to work, but it sometimes gets too hard. So what are those things? What can we do to help promote those things? If it's a good idea, can it be adapted or rolled out somewhere else? Or what's the impediment that could be removed that stops us all regardless? We'll hear some of those good ideas today, and we will help to push them, and we hope they will. If they resonate with you, if you hear something you think would be a really good area, move in your area, and do you need some support to get it running, let's hear it. Throw it in the chat. We need to know what will work, and we want to be able to promote it. And you guys together have a hell of a lot of strength for that, and I encourage you to be part of it. Anyway, thank you.
Thanks, Al. It's Kathy, everybody. Thanks, Al, for providing that bit of context and setup for the day. What we're going to do now is move to our range of speakers. So these are just going to be rapid fire, quick little presentations about what's happening in various quarters across allied health service delivery in rural and remote settings at the moment. So our first speaker this morning is Caitlin Horton, who's a speech path, and she also works here at SARRAH, but she does have a clinical role and runs her business at the moment. So Caitlin, over to you.
Thank you, Kath. Just before I start today, I'd just like to acknowledge the traditional custodians of the land on which I'm sitting today, which is Gubbi country up in the Sunshine Coast, Queensland. I'll get started. So as Kath mentioned, I work for SARRAH as project officer, but I'm also a speech pathologist. I've worked in a few different settings across regional, remote and very remote locations, in a few sectors in education, health and the private sector, predominantly as an NDIS provider. Today I'm going to discuss some of my experiences working with that disability sector. I'm sure nearly every clinician in this room has had some change to your service or service delivery since the NDIS has rolled out. Whether or not you provide NDIS services, it's definitely shifted the way in which people are able to access allied healthcare in our country. Just because I don't have a lot of time today, it's just a very quick talk. I'm just going to focus on some access problems that we have in getting participants or eligible people to access the scheme in rural and remote communities. So some of the experience that I've had have been when visiting small rural towns or communities or Aboriginal communities. I am approached with referrals that I can't assist because people do not have access to the funding or means to pay privately. And by that, I mean specifically that there is a person with a disability who is eligible for the scheme, who does not know about the scheme, does not know how to access the scheme, or is waiting sometimes up to 12 months to become a participant of the scheme. Another situation is where a person has tried to access the scheme but have been rejected either because they do not have the literacy or language ability to read the correspondence that the NDIA are sending. They do not have access to a telephone due to having no reception in their area, or they cannot afford a telephone, or they've been told that they need to purchase new identification documents, i.e. new copies of birth certificates that they cannot afford. They cannot afford to get access to the local courthouse. They cannot afford to buy a new birth certificate. Obviously, this is very frustrating when you make an effort to visit or you have an organisational plan to provide outreach to a rural community. And when you come up with these kinds of barriers. So what could we do about this? Obviously, there needs to be some shifts that come from the NDIA in the way that it engages with communities and allied health practitioners. In my experiences, I met often with the local NDIA office to ask them if they would visit these communities to help people to learn about the scheme and gain access. However, I was never successful in convincing the NDIA to make such a visit. Some of my thoughts about other ways we could increase access to the scheme would be increasing the availability of NDIS access clinics, such as have been trialled in small rural centres and Aboriginal communities in the Northern Territory, and extending that to more regional and rural areas of Australia. Increasing the capacity of the organisations who hold the NDIS contracts to complete community engagement to support eligible participants to get onto the scheme. By further resourcing this, they could have more designated and identified positions to support our First Nations communities, including re-resourcing the Early Linkers program, which I have heard was quite successful. Limited understanding amongst the local area coordinators and planners about childhood development and health or disability in general means that they have less understanding of the importance around reducing waiting times for access. As clinicians, we know how important a 12-month wait is for a 7-year-old child to their development. One recommendation that OT Australia has made is to utilise occupational therapists in the planning process for the NDIS, or to be advisors to this process. My last suggestion is to review the block funding models and reinstate block funding models for remote and First Nation communities. One thing I'd like to touch on today is that the Queensland State Government has actually recognised the failure by the NDIA to provide access to the scheme and taken steps to assist vulnerable populations with their new assessment and referral team, which is called ART. This is currently being rolled out in Townsville, Mount Isa, Mackay and Far North Queensland. We might even have some members here today who might know more about it, being from those areas. Amazingly, it's assisted 1,700 people since September this year to gain access to the scheme.
Wow.
And while this is great, I think that it is an extraordinary measure for a federally funded scheme and indicative of how the scheme has failed to provide access to people in regional and remote Queensland. And I'm just going to extend that to across Australia, given my experiences in New South Wales and Northern Territory. So just because I'm here today saying that people need better access to the scheme doesn't mean that allied health professionals in rural communities are in need of more work. Most of us have waiting lists or closed books, but we know that it's important that everyone who needs the scheme has access, and allied health professionals can better plan our workforce if we have a better idea of the community's need. Underutilisation of the NDIS is masking how many services are actually required, which in the end just places further burden and expense on our health system. So I'm about to finish up. There's so many things I could talk about with the NDIS, and I'm sure our other presenters are going to touch on them. But obviously another common situation that is frustrating is NDIS participants who don't have access to capacity building supports because there are not enough allied health professionals in their community. So obviously we'll hear more about this today and the solutions to that, including redesigning our service delivery and funding models to support allied health assistance, using telehealth and the allied health law generalist pathway. So thanks so much everyone for your time. I'll let the next person speak.
Thanks, Caitlin. It's great to hear the perspective of people who are delivering services on the ground. And I really liked your point around that, you know, while most allied health professionals have waiting lists for services, that it would help people to plan better if they had a better understanding of community needs, and so more information sharing is required. So thanks for that. Our next speaker is Dr. Nerida Volker from TAFE New South Wales. So Nerida, I'm going to hand over to you now.
Thanks very much, Kath, and hello to everybody. Let's see if I can actually share. Oh, it says host disabled participant screen sharing, so I can't share my screen. Let's see. I am here actually at Sarah's offices, so in the coffee room. So if anyone wants to come around. Oh, look, there we go. That might be. How are we going? Can we see that? Aha. Can we see something there? Awesome. All right, let's see if I can get that on the right one and not use up all of my time. So hello everybody, I'm Nerida Volker and I'm from TAFE New South Wales. I'm the industry lead, which is for allied health. It's a really unique position. Probably nowhere in Australia is there somebody in my kind of role. I'm an allied health professional by background, have spent all of my career really working in allied health workforce in various iterations. My very first job was in Cowra as a baby dietitian many, many moons ago. And so this is an area that I'm super passionate about, but also I guess have done the hard yards with many of you in the room. I've been with TAFE New South Wales for 2.5 years, coming from higher ed, and I see so many opportunities for us to work together to really build access to allied health services. And I just thought my 5 minutes, I have 5 points about what I think are the real opportunities and I guess the pain points that I also see in relation to building allied health services in rural areas. I would say that I need to hear your collective voices. So the needs of allied health services and particularly around the training needs for allied health assistants is largely invisible in the training sector. And that's not because the demand's not there. I know that everybody in this room knows that we have really significant and critical issues around access to allied health services, particularly around the NDIS and disability services. But the way allied health assistants in particular have grown as a workforce has been so quick. We like to also give everybody very different fancy names. So it might be an allied health assistant, it might be a therapy assistant, it might be a habits coach, it might be a therapy aide. All of that language is really difficult when you work in a system that is very highly prescriptive, highly regulated, highly compliance driven and highly driven by, for example, training packages that are very siloed and specific. So we hear a lot in my world around the care workforce, absolutely the aged care workforce, the disability workforce, and and mental health workforce. When you scratch down, most people are thinking in their head, disability support worker, aged care, personal care workers. They are not thinking about an allied health therapy assistant and allied health services. So some of that, as everybody, most people in this room will know, is data is a big part of that. So that data that's coming up is not actually representing that workforce and what they're doing. But we also know the nature of our work is that often you're working in your own businesses. We are a kind of a decentralised sector, particularly in the disability sector. And this is why a forum like this is great, because we need those voices. I need you talking to Training Services New South Wales, for example. Outdoor recreation, I'm about to go to a forum next week where the outdoor sector have lobbied Training Services New South Wales. They have a sector plan. They have, you know, incentives for skill sets and training and communication to schools about the importance of a pathway into an outdoor sector career. And I don't get that for allied health assisting. We can deliver really high quality training at scale. We can't do it without great teachers and without a flexible mindset. The way in which we do that delivery. One of my biggest barriers to delivery is not having enough teachers, in each speciality. Now, that's not a surprise given we don't have enough people to actually do the work. So that's got to be a discussion. It's got to be something we work on together. We don't want to be taking people out of the sector to come and train. You know, given the market at the moment, you know, we can't afford you anyway. So how do we actually work together to come up with some better solutions around that? We need to work with you. The flexibility about training mindsets too is thinking, COVID's been a really interesting journey in terms of things like telehealth, where, you know, 30 years ago, we've all been doing that for a long time, but now it's obviously BAU. The same in terms of connected delivery and flexible delivery models in vocational education. At the start of the pandemic, that was like something that was a really taboo kind of not something that we can do thing. We didn't have a lot of capability around that internally. That has now obviously really become, again, BAU going forward. So we can deliver really interesting models of training. We can do, we can take a group of people and train a group of trainees virtually together for one company. We can have hubs for skills assessments in local communities. Like, there's lots of things that we can do that are different, but we have to come again to the party and work together. We need to work with you for high quality placements. Biggest barrier for us taking more students is we can't offer high quality placements. And to me, where we should be looking towards in terms of what is a high quality placement is a multidisciplinary placement. We need our health professionals and our assistants to be training together. They need to have those experiences as teams in their placement experience to ensure that we are actually getting them work ready and hit the ground. We need to work with you around these bespoke training products too. The new training package for allied health assisting is about to hit the deck, probably by the end of this year, but it's still a very narrow, very linear kind of training package in terms of thinking about an allied health assistant doing one particular role. We need to work with the sector, particularly in disability, to build those training products that are actually ensure that we are building, taking units from a range of different kind of qualifications and perspectives and sticking them together, or building skill sets for when you've got an existing workforce, and how do we build that, enhance that, that workforce over time in those multidisciplinary, interdisciplinary and transdisciplinary models, which we know are happening, but we are expecting to grow. And we need you to value allied health assistants as a career. This is really important. If you keep employing allied health professional students as assistants and therapy assistants, great for your product, your pipeline in terms of getting those very much needed new graduates, really important. But we want to be able to communicate to young people in rural communities that allied health assisting, therapy assisting, habit coaching, whatever you want to call it, is actually a really important career option. They know their communities, they TAFE career and vocational education. We are the entry point to education for the underrepresented groups in our health workforce. And we really need you to value those things. And if they're just seen as something that's a churn kind of activity, not valued, not built upon, and not given leadership kind of opportunities, then it's very hard for us to promote that. So we need to be all on board, talking to young people and to older people in communities who maybe are coming back into the workforce about the value as a career. So I might just finish there, but thank you for listening.
Thank you. Thanks, Nerida. That was great. And thank you to those who were adding their comments to the chat as well. There's some really great stuff in there. So, you know, the immediate takeouts for me were around that we need to address the need to have the Cert 4 in workplace training because that's a barrier to getting more teachers on the job. We need to look at RPL, and we need to consider the fact that there is a degree of competition happening between allied health professionals and allied health assistants in terms of clinical placement numbers. But some great discussion points in there that I'll ask people to hold on to and come back to later. But thank you, and keep contributing to the chat function because it's really valuable stuff. So our next speaker is Rachel Tosh, and Rachel is the CEO of Therapy Alliance Group Queensland and a speech path by background. And so Rachel, I'm going to hand over to you now.
Thanks, Kath. So obviously, you know, workforce issues for allied health around recruitment, retention, you know, skills gaps, high turnover, attrition due to burnout, mental health, especially in regional and remote areas, is not a new thing. I feel like in the time I've been a speech pathologist over the last 20 years, it has gotten worse and worse, and we are now in a position where I feel it's worse than ever. We have a nationwide shortage at the moment. For example, according to SEEK, the #1 hardest vacancy to fill right now across the country is a position of speech pathologist. So from my perspective, I see 3 key factors at play. #1 is that the funding models just don't match the desired outcomes. For example, as an organisation, we don't provide DVA services or Medicare bulk billing services because we lose money every time we deliver those services. The rates don't even cover wages, much less overheads, and they have had minimal increases in the last 20 years. The NDIA is now looking like it's going to follow a similar sort of pattern in that they haven't increased therapy pricing for almost 3 years now. In that same time period as an organisation, our wages and payroll related expenses have increased by more than 17% because we're desperately trying to attract and retain team members to regional and rural communities, and even trying to attract them in our lower socioeconomic metro locations is really, really challenging in this highly competitive environment currently because of the national shortage that I mentioned. The second key factor that I see at play is that there's just a massive lack of communication, collaboration, cooperation and trust within and across sectors, which is really preventing innovation from occurring. And then the third element is that I feel like therapists and clients or providers and participants, to translate for those who are fluent in NDIS-ish, we're really being strangled by red tape at the moment. And like just a little simple example, a couple of years ago, I had to help local GPs complete the NDIS access request forms because they couldn't get any information from the NDIA on how they were supposed to fill them in. They were getting rejected for patients who were amputees or had other really obvious permanent disabilities simply because of a poorly worded question meant they ticked one wrong checkbox on that form. So that's just one example of that red tape that's just choking the sector right now. So just by way of background for me personally, I've worked across the private sector, the public sector, disability, health, education, community, acute, UK, Australia. I've worked across multiple funding models, DSS, the HACWA and the Better Start for Early Intervention for Disabilities funding, NDIS, Medicare, DVA, work cover and more. And in a past life, I was even the lead project officer for the Allied Health Rural Generalist Pathway when it was first being developed. So I started a private practice in Toowoomba back in 2012 and we grew really rapidly. We added OT, physio, dietetics and evolved into Therapy Alliance Group, also known as TAG. And in 2018, I had a fellow speech pathologist in Chinchilla who approached me in the hope that we could try and keep the local service going that she'd founded there. We not only kept it going, we added OT and we also added a paediatric physio outreach program as well. Shortly after we took that on board, which I'll say was not a good business decision. It was something that we didn't do for that reason. We did it because we wanted that community to have access to services. So shortly after that, I started increasing my effort to raise the Chinchilla and Toowoomba allied health workforce issues, that the lengthy wait lists, the shortages, the difficulties with recruitment and retention, and also to offer potential solutions. So I engaged in forums, in pricing committees, parliamentary inquiries, I wrote written submissions, and in all honesty, like at this point, after years of this, I'm really tired, I'm really jaded, but I keep going in the hope that maybe today will be the day that someone will have some kind of leverage and has a seed of an idea planted or a spark of fire kindled that can lead them to influence or action in parts of the systems that I can't directly affect. So anyway, one of the things in 2019 that we trialled was using a locally trained allied health assistant. So it was a local who we had trained as an allied health assistant, paired together with a remote speech pathologist via telehealth to deliver interventions for clients who wouldn't normally be considered suitable for either allied health assistant or telehealth services. Independent, like allied health assistance, it's only clinically appropriate for some clients, and similarly, telehealth is only appropriate for some clients. The vast majority of clients that we see under NDIS plans have disabilities that mean that they have reduced capacity to engage in these sorts of service delivery models. But this trial where we paired those two up together worked really well. It helped to overcome the tyrannies of time and distance, as well as enabling us to match up that limited resource of the therapist with the local context, with the local who knew the families and the context to be able to optimize that engagement with the service. It worked really well from a clinical perspective, but it wasn't financially viable. The hourly rate and the way of billing under the NDIS didn't fit for that sort of an integrated service delivery model. The allied health assistant hourly rate is too low to even break even. And we were told that we couldn't, and we were also told that we couldn't bill simultaneously for both an allied health assistant and a speech pathologist for the one consultation. You know, being the tenacious sort that I am, I proposed a pilot program to the NDIA to try and keep our chinchilla services running, plus the added benefit of delivering local jobs and better quality, as well as more affordable services than traditional outreach programs. I put forward a proposal that where costs would be minimal to the NDIA and adjustments needed were really minor tweaks rather than major changes. There were no legislative adjustments required. We were already on the ground in the community. We had the infrastructure, we had the local knowledge, we had the contacts and everything that we needed to make it work. We had the resources. And I warned them multiple times throughout that period that our allied health services for chinchilla were at risk of imminent collapse, and highlighted how urgent the situation was and how many people were being affected. So fast forward about a year after that, in February 2020, I finally secured a meeting with the Director of Queensland Provider and Market Relations. I outlined the issues to her. I shared our ideas to solve them. She seemed genuinely interested. She asked for a written summary to investigate that innovation funding or something like that. So I sent through a written draft proposal, again, prepared in my own time, on my own dime. And then our next meeting, which was already scheduled at that previous meeting, was cancelled by her office. I was told it wouldn't be rescheduled, and I was told there would be no further meetings. No response to my questions were provided, no reasons were provided, and I never did get a response to the proposal that I spent hours formulating. So after a 3-year battle, we've made the heartbreaking decision to close our local chinchilla service due to ongoing recruitment and retention issues. So that community and more than 100 active clients in that community are now without speech, OT and paediatric physio services unnecessarily. Shortly after we made that closure announcement, I had 3 phone calls and 2 emails from LACs and their managers. Suddenly, everybody wanted to talk to me about those clients, the needs, and after actively ignoring our repeated pleas and warnings of service withdrawal for 3 years. They demanded urgent meetings where they asked me to tell them what our solution was to help participants transition and minimise risk to the local community. And then to top it all off, one of them asked me to provide them with a list of affected participants in that region. So once again, the NDIA and their partners were asking and expecting us to do their job, to fulfil their duty of care, and to do that on our own, out of our own pockets without recognition or thanks. Now I'm at a point where I'm actually really worried about our Toowoomba services too. We already have extensive waiting lists in that area. And just in the last 4 weeks, we've lost 4 of our speech pathologists there because they have to relocate back to metro areas for family reasons, or they've been headhunted to Brisbane or the Gold Coast. If we keep doing what we're doing, our regional and rural and remote workforce will keep deteriorating in both quantity and quality when there are already critical issues and shortages there. I see a lot of options. Now, all of this sounds really depressing, but I actually see a lot of options to address these issues and improve or change the current trajectory that we're on nationally. For example, The allied health assistant paired with telehealth model that I discussed, it's just one example of a viable alternative service delivery model. Other ideas are that we can increase university places for allied health and enhance access, specifically targeting rural and regional applicants for those places. There's work to do to clarify and improve flexibility in how services can be billed under the NDIS. We've been asking for clarity around that for years, and it still remains where we don't have those things clearly in writing. We call and we ask for answers, and we get 3 different answers from 3 different people. The NDIA needs to stop cutting the capacity funding building in NDIS plans. Therapeutic interventions have been shown over and over again to reduce future costs, and the NDIA is basically killing a golden goose every time they cut capacity building funds in plans, because that is how taxpayer dollars are saved to enable the plans of the future to be funded. So anyway, I'm hoping that our experiences and from today, we can find some common ground and actionable steps forward to help address some of these important issues. And so I look forward to hearing what others can share too. Thanks.
Thank you very much, Rachel. And it is, so heartbreaking to hear those stories about people who, and the really difficult decisions that you're needing to make, business decisions that are affecting entire communities. And I'm sure that I'm, speaking on behalf of the group to say, what a fantastic job you're doing and what a difficult decision that must have been, and we empathise with you. So lots of great takeouts there, but in the interest of time, I will move along. But please, people, keep contributing to the chat function. I'm going to move on now to our next speaker, who is Chantel Robards from the Boosting the Local Care Workforce program. So Chantel, over to you.
Hi everybody, thank you so much. Thank you for having me. I'd also like to acknowledge the traditional owners of the land that I live and work on, who are the Awabakal people, and pay my respects to their elders, past, present and emerging. Thank you. The Boosting the Local Care Workforce program, for those of you who aren't familiar, is a national program funded out of DSS. We have representatives in every state and territory. We have a couple of, just very briefly, a couple of jobs, sort of key functions, I suppose, one of which is to gather information from the market, the care and support sector market, and be delivering those pieces of information back to DSS to support their policy decisions, and also providing support to the market to try and build workforce, which, as we've heard over and over again, how challenging that is right now. I'm in the team as the Allied Health, fancy title, subject matter specialist. I am also a speechy. There seems to be a lot of us here today, so that makes sense because we're awesome. And I've been in the disability sector since graduation, which is back when the dinosaurs were roaming the earth. So have been here right from the iteration of the NDIA. I'm based in the Hunter, so I really have been engaged with the NDIS for a very, very long time already. I guess so today, Alan kind of asked me just to bring some of those, what we're hearing, information, and I guess just building on previous speakers here. I'm just going to be glancing at my notes over here as I go. I guess that we all, just to state the obvious, we kind of know how we got here. The workforce is pretty dry at the moment. It's dry in metropolitan areas, which always gets very, very frightening, because if we can't recruit in the middle of Sydney, then how are rural and remote areas ever going to find somebody to fill their positions unless they happen to find that person wanting to make their tree change or sea change at that time? Really, really tricky. We know we got here because of the injection of NDIS funding into the sector. Demand just way, way, way outstripping supply at the moment. Even with plans often being cut, funds being cut, there's still not enough allied health professionals to go around, and we don't want to be solving the workforce problem by not giving people enough funding. So, we need to continue to build this workforce. And as we know, with a 4-year degree, that's not going to be an overnight proposition. So what people are telling us on the ground is just stating the obvious again, attraction and recruitment issues, new grads demanding way above award salaries, which is then impacts business. Retaining, as we just heard from Rach, she's just had some team members headhunted, and that's the way things are rolling right now because the demand is just so enormous that there's only a couple of ways really to source workforce, and headhunting is one of those ways. So retention definitely an issue. The red tape that everybody's alluded to if you're moving in the NDIS space is insane, especially registration. So we still hear registration challenges coming up from our allied health providers, especially those who are trying to hang in there and remain registered for early childhood support, and people and their decision as to whether or not to continue to pursue registration based on just that significant shift towards NDIS participants plan and self-managing their funds and balancing off making the business case, I suppose, for remote. But also assistive technology. So the assistive technology space is one that I want to do a little bit more investigating in the coming weeks with anyone who wants to talk about it. Just get in touch. I hear your frustrations on that and the amount of time spent chasing down applications and trying to figure out why things have been knocked back, and again that communication issue between the market and the agency that just has been ongoing forever. And then underlying all this, of course, we've got a pricing review happening right now in the NDIS space that people are a little nervous about. Rach has already kind of alluded to the viability of the current rates, which I mean, I've worked with businesses here, locally, 5 or 6 staff, busy, end of financial year, $2,000 profit. They're not this illusion that the NDIS is making everybody billionaires. Certainly doesn't seem to be the case. So I know there's some nervousness that's sitting around the current pricing review, and we're all watching that space fairly closely, especially when you're having to pay so far above award to try and retain staff at the moment. That's really eating into everybody's bottom lines. We have a number of businesses attempting to introduce allied health assistance, taking on board what you were talking about, Nerida, which was all 100% true. We're in a really tough space right now. I mentioned headhunting as a successful successful way of finding staff. The most successful pipeline I'm seeing right now is that pipeline where businesses are taking students for placement, offering them allied health assistant, and then keeping them on until graduation and recruiting them immediately at graduation. And that, unfortunately, is working for them. And I know they're not going to be quick to drop that for the purpose of bringing on a Cert 3 or 4 AHA, because right now the desperation is recruitment, and they're doing whatever they can to get there. Around policy, of course, we have that workforce plan, as Alan talked about right at the beginning. Student placements, we're really doing some work in that space at the moment to see how we can support more student placements into rural areas, into remote areas, and into the care and support sector in general. We know if students place in a particular sector, they're more likely to seek work as long as that placement is positive, of course. I personally had a horrendous one in acute care and was never, ever going there after that. So I think, it's got to be that positive placement. So what supports can we put around these placements to make them positive, to attract students into, to support providers to be able to take students? We do see that as a really important pathway to be able to attract students into more rural positions, and we're working with DSS right now on that. Allied health assistant, as you know, is another spot in the workforce plan. We've all spoken quite a lot about that this morning. It's definitely a way to have a bit of a quick win in terms of building capacity within your business. However, lots of questions sit around it. we'd like to embrace it, but allied health professionals, I think, really are asking for a lot more support in understanding how to make it work for their clients, for their business. There's viability questions, there's insurance questions, there's delegation and supervision questions, and then there's that overarching in the care and support sectors, particularly around the complexity of our clients, and we can't be, as Rachel said, it's not a suitable model for absolutely everybody. And so who is it? You know, we haven't done the work to sort of pull that apart, I think. You know, who is it appropriate for, who is it not appropriate for, and who's got time to do that work right now when we're all short-staffed because we can't recruit. You see, we're going round and round and round. There's gaps in data that's been acknowledged, and I'm hearing about little projects around the place that are popping up looking at the data, but I'd really personally like to make sure we're asking the right questions in terms of data, not just how many jobs, not just what are the vacancies, what's the length of the vacancies, but are we attracting the right people into the degree in the first place? I mean, we've got ATARs in the land of ridiculous now. You know, how many HSC students just look at that ATAR and think, oh, I'm not going to get that, and just walk away from allied health before they've even sort of looked into what it's about. It's right up there for really with medicine in some of the disciplines and some of the institutions. So is that the cohort that's best matched to allied health? You know, have we even asked the question? Have we done any sort of had a conversation around that? And for me personally, just observing things over the last 20 plus years, I think, yeah, we have these people who are obviously good at learning. They're getting ATARs at that level. We're attracting people who are good at learning. And if they're coming now into the fee-for-service market and you're in a situation of churn, billable hours, some professional development, but it's probably capped because of financial viability, some supervision, hopefully, if you've been able to access it. How well are we supporting those people who love to learn once they get into their job, and how is that affecting retention? So, you know, just some of these kind of deeper questions that I'd love anyone who's collecting data to be really starting to poke around with. And then it's the place-based stuff, you know, how do we facilitate more people who are living locally, living rurally, to be able to access AHA course that's appropriate for the sector they want to move into and culturally appropriate, because we certainly have heard some interesting stories around allied health assistant course like the Cert 3 and 4, where it was tried to be implemented with some Aboriginal people, and the course content was just not okay for that particular cohort. So, you know, there's probably some work if we're really looking into community that needs to be done there too. So around some of the little projects that we have sort of ticking over, we've got to really take Rach already has piloted. We actually are getting a little bit of movement in the Kimberley around a blended telehealth AHA model that, and we've found some highly motivated people inside the NDIA. So we're looking really closely at whether or not we can make that work. So Rach, please hang in there. We're working as fast and hard as we can. I'm really hoping we can pull that out before you have to close your doors in Chinchilla. And we will keep, I just tripped over Rach's pilot by accident. That's just the nature of my job, as we were talking about student placements, and then we got onto that. And that's, so please reach out at any time, because sometimes these intersections just happen by chance, but it's very, very timely. I know Kath Cosgrove, who's on the call today, has done some amazing research around whole of community recruitment in Shepparton in Victoria and some other places and I've been very fortunate to be able to be sort of involved in at a fringe kind of level, but more so intensively if needed down the track in Taree in New South Wales, where they're looking at implementing a similar or even the same model there. So we're having a bit of a crack at that. So I know I've just talked really, really fast to get through everything, but hey, how much of a sigh of relief did we breathe when NDIA pulled up on independent assessments? I was thinking, where on earth is that workforce coming from? The added pressure that just would have that would have placed on allied health would have just been nuts. So at least we got a little bit of breathing space there. Okay, that's probably me. I'll stop there because there's other people waiting to talk, but thank you so much. Please don't hesitate ever to reach out, and yeah, onwards.
Fantastic. Thank you, Chantel. That's that was quite a fast ride through quite a lot of subject matter there, and there's been some really great contributions to the chat as well. I'll just pick up on one point, but there were lots that could have been pulled out of that. Well, 2 points maybe. Undergraduate student selection. I think that that's something that, you know, collectively we need to really think about. And this, to be taken as a comment, is just, you know, that tension between fee-for-service environments as opposed to what most businesses are doing, which is running on goodwill. And so that's the situation that many business owners are finding themselves. But thank you, Chantel. Really appreciate your time today. Moving on, we've got 2 more speakers. I'm going to move now to, 3 more speakers. Ed Johnson. Ed, over to you.
Thanks, Kath. I'll try to keep this brief. Kath's just asked me to share a little bit about the business that I run and how that seeks to address inequities in accessing therapeutic supports through the NDIS. So a little over 4 years ago, I founded a company called UMBO, which is a social enterprise that seeks to provide allied health supports to people in rural and remote areas, sort of a gap-filling service where other services don't tend to go. I came to the decision to kind of go on the pathway that brought me to running the business through starting my career as a new graduate speech pathologist in 2011, working for a state-based disability provider. One day I was servicing quite a large region and had a client who had been waiting for, as far as we knew, at least 4 years to see a speech pathologist for communication and swallowing difficulties that they were having. They were 6 hours from where I was based, and I was really excited to be able to work with this family, because when I spoke with them on the phone, they had it sounded like they had had a terrible time in accessing any kind of service, whether it was allied health or otherwise, and just you know, an ear to listen to their issues went a long way in the first instance. So I was planning this trip for a couple of weeks, and a couple of days before I was due to go, my manager called me and said, Ed, I've seen you have been referred to this person in town X. You can't go to see them because you can see more people at home. So this is a state-based disability service where the state is making the decision that a citizen cannot access government services because they say so. And I wasn't okay with that, and still am not. So I started a PhD to figure out what families thought of things like that, and found that that was not an isolated case. That was happening all the time. Families were giving up left, right, and centre because they knew that this was going to happen. So I thought, what do we do? And I asked families, what do we do? And they said, we don't care how we get help. We just want help when we ask for it. So we tried using a combination of co-workers in community with technology to help children with complex disabilities. So these are kids who might be non-verbal, might not be able to mobilise very well independently. and who, because of the lack of exposure to allied health, have had currently a very low quality of life. And we were able to successfully deliver services that were clinically effective, that were socially acceptable, and that families, communities and schools wanted more of. And I thought, well, okay, I proved this model. I can't just stop there. So I met a couple of people who are very into social change and started a business that would help to solve that problem just over 4 years ago now. So we continue to come up against negative attitudes towards our service because I think the coronavirus epidemic or pandemic has shown us that now everybody has a little bit of knowledge about digital practice and how therapy might be delivered online, and see it sometimes as Zoom plus business as usual, which is definitely not the case. It's far more complex than that. And there's a lot more work that goes in, both from the clinician and from the supporters at the other end, and the focus person at the other end as well. So those are some barriers that we're facing to a model that's showing us that we have success and that we can upskill communities. We can't just help individual people in those situations or individual families, but what we're seeing is that both in my PhD research and also in clinically at UMBO, we're seeing that co-workers at the other end, or generalist clinicians who we're connecting with, or family members, they are applying this to other people as well. They're learning skills that they can then use to not start at step one when they're engaged with a clinician the next time. They start at step two perhaps, and slowly build capacity in the community, which sees them being more independent and less reliant on us in the future, hopefully. Thanks, Kath.
Thank you. Yep. Thanks, Ed. Okay, so I'll keep moving on because we are starting to get a little bit pressed for time. I knew this was going to happen. So our next speaker is also our SARRAH board member, Jeremy Carr from Back on Track Physio. Jeremy, over to you.
Thanks, Kath. I will try and keep it brief, but thanks for the opportunity. So our clinic is located in the Southern Murrumbidgee region along the New South Wales-Victorian border. We engage with dietitians, physios, OTs and allied health assistants to help support our participants. Again, I guess so many shared experiences with everyone. It feels good that we're in the boat with lots of other people. We have the same things that everyone else has talked about before. Our main issue is the availability of workforce. And when we get workforce, they're often new graduates or very early graduates. And so our main concern with those guys is their clinical competence and confidence, which often leads to a little bit of hesitancy in providing services to complex clients. But not only the clinical side of things, I guess we also have concerns and issues with administration competence and confidence, and trying to assist participants navigate through the NDIS and the reporting requirements, and also advocating for them in part of their plans, and also echo the concerns regarding registration and the accreditation requirements there. From a smaller private practice where you're often overwhelmed with clients, it does take a lot of extra effort and time to try and navigate that. And again, also with the other thing we would echo is that it seems like everyone's in the same boat, and it's frustrating that we continue to have to compete with each other to try and recruit and headhunt other clinicians and fight amongst ourselves as allied health clinicians. And so I would be personally advocating for direct correspondence and working together with policymakers, with allied health clinicians, to try and lead that response, so that we can create a tide that lifts all boats, and we no longer have to compete with each other to recruit to. So thanks again for the opportunity. As again, we just continue to echo the thoughts of all the others that have already presented. Thanks, Kath.
Great. Thank you. Thanks, Jeremy, and thanks for the brief presentation. But you know, we'll hopefully be able to circle back on you with some questions later. Our last speaker is Mark Drury, the CEO of Dundaloo Support Services in Taree, New South Wales. I had the great pleasure of visiting Taree earlier this week, although it was quite soggy. I hope that things haven't progressed too far down that path. But Mark, over to you.
Hi, Kath, and I can tell you it is still raining. Hasn't changed. I'm going to be really brief because I know you're way behind on time, okay? I just wanted to bring out a couple of things. One of the big issues that we've had here in Taree is that we've really struggled to try and get some quality data. And one of the big reasons is because unlike the medical system, which are all under that, that one umbrella, and you can gain data about who's going where, all that sort of thing. Allied health are all higgledy-piggledy all over the place. So speeches have got their own thing, the psychs have got their own thing, and trying to gather that all together has been extremely hard. We've come to the stage where we've decided we just have to do our own data research to be able to pull that together in a very short way. One of the other things that I'm doing is, we were talking before about allied health assistance. I've started to go down the path of employing allied health professionals who are in their training, who are still undergraduate, employing them to gain some experience as an allied health assistant so that they can put that towards their allied health training. And I've also got the luxury of having really high quality support workers. So I have about 200 staff. So being able to pick out some of our really high quality support workers and then put them in a position where they can learn to be allied health assistants, that's still in the early stages, and I'm not convinced financially that can work yet, but we're giving that a shot because it's freeing up time for our allied health professionals. One of the positive things that's happening in Taree is that the problem is so desperate for us in Taree that we've been able to get a really significant group of people together who all desperately want to fix the problem. And that is including the public sector, private sector, and all of the different variations of private sector as well, with us in disability, aged care, early intervention. We've also been able to get the universities on board with us, and we've been able to and the council, we've been able to sit around the table and actually have several really decent discussions about what plan we need to do, well, plans, because there is no one solution to this. It's so multifaceted that there's just a whole bunch of areas we need to work on. Broadly though, we can see that it fits in two main categories: that we need to target our students through school and then the undergraduate process, and then that collaboration process after graduation. That's one target area, and getting that done really well. And then the other target area is, how do we attract allied health professionals into a regional area like Taree? And then how do we retain them? And so we've been doing a lot of work with Kath Cosgrave, and she's got some awesome research, which is really showing that we need to be able to develop those community connections so that those allied health professionals aren't just here about work, they're here about the community, and they're putting their roots down in the community, and they're actually living here and enjoying being here and becoming part of the community. So they're our two main focus areas. I think maybe for us, when it's so desperate, we're all willing to come to the table and put our hats aside and actually find a solution to the problem. One of our big issues is that we actually have the Federal Minister for Rural Health as our local member, and he pretty much believes this is a state issue, and that is just not a good place to start. So that's something that we need to work on to get the federal government to come to the table more, and the state government, so that we can try and find some solutions. But yeah, thanks, Kath.
Thanks very much, Mark. I know that you could have spoken a lot longer on a lot more issues. So, but thank you for focusing us around those couple of key points. So now that concludes our range of lightning talks, which might not have been quite as lightning as we were hoping they'd be, but were still, you know, very essential scene setters nonetheless. The next part of this session is just to provide an opportunity, I guess, for people to ask some questions of the presenters, but also of us, and through that discussion start to formulate some solutions that we can kind of pull together in a coherent way. While people are thinking about what they'd like to ask, although, you know, there's probably people there clamoring to start asking questions and to say things. So, you know, I invite you to come off, you know, to switch your cameras back on and you know, put your hands up if you're wanting to make a statement or ask a question, but just, you know, by way of trying to summarize some of the stuff that came out of that, you know, going back to Caitlin's original description of you know, some of the key challenges in trying to deliver services to communities. So she talked about access first and foremost, being challenging for the individual trying to access services as part of the NDIA or the NDIS. And so there's some work to be done to shift the NDIA's focus and the way it connects to communities. She also made that point about allied health professionals having waiting lists but needing a better idea of the community needs so that they can do some planning. So getting access to that level of data would be useful. Nerida then spoke to us about the important role that allied health assistants have, with those key messages around allied health assistants in and of themselves being a valuable and valued career. And we all have a responsibility to carry that, I guess. But the chat suggests that there'll be some tensions between those allied health assistant training opportunities as opposed to a recruitment strategy, which is to take on allied health students as allied health assistants. So I think that's something that I'd certainly like to hear some further discussion on. Rachel gave us a very impassioned presentation on her business and some of the things that she has done to improve access to her services for communities, and some of the very significant challenges that she has found in doing that. And one of the key points that Rachel made was around the lack of collaboration, cooperation and trust between sectors that is getting in the way of innovation. And I would hope that today's session is an opportunity, given some of the chat that we've seen around the need to incorporate all of the players in a location, including the public sector services, the hospital services, the private sector, and those disability service providers. We then heard, I won't go through it all because you don't want to hear me talk, you know, but there's some fantastic points made. Chantel gave us a great potted view of the disability sector in general and some of the challenges that she's seen, and she's right in the middle of it. So, you know, very, very hands-on. And she raised those issues around the undergraduate student selection. And then, so yes, that's as much as I will say there. I have a note here that Al would like to talk to us just before we open the mics. So Al, would you like to have a moment?
Just very, very quickly, on the, I think it's been a really important discussion in terms of workforce and the allied health versus allied health practitioners, assistants, all that sort of thing. I think that Jeremy probably made the point that we're in a situation where we feed on ourselves and we sort of have to, and that happens in the whole education and workforce space. So our answer here is to get a systemic fix to this, so that isn't the case. There is a lot of, every issue that's been raised here about RPL and lack of, the competition is true, but we are, at a nation, we are facing 250,000 jobs needed, and a lot of them are allied health and allied health assistants, like 30 and 40% increases in some cases. We need a system that enables that workforce development and for it to be distributed. So I just want to emphasise, let's not turn this but you, and I know that's not the flavour here, but let's keep it constructive and high. That's a really important issue. The other thing is we've got a couple of people listening in here who are officials in various departments, and as an ex-official, and many of you guys are as well, I know that there are many of those people who can't say much publicly but are inclined to try and recognise and push these issues. So let's encourage them to do that. This isn't to put you guys on the spot, but if you need to tap into the sort of people you're hearing from today, please do so, and don't be shy of coming to Sarah for that or going directly. It's such a crucial thing. And the other thing is, I just thought that Rosalie Boyce raised a really important point that was in the discussion, and I was wondering if Rosalie wanted to bring that in. It was just one of those issues that is just fundamental about interactions, etc.
So would Rosalie like to just have a moment to speak to that? Is that okay? Can I put you on the spot, Rosalie? I know how you hate speaking.
Sorry.
Can you hear me? Can you hear me?
Yes.
I can't put the video on, I'm sorry, because I'm in a cafe in
Okay.
Brisbane at the moment.
Again.
Yes, I am on annual leave. Look, I'm really fascinated by the fact that whenever they talk about bringing stakeholders together, there is never public hospitals and health services into that that pitch. I'm also noting that the is it the December NDIS workforce implementation sector briefing that's on? Again, there's no mention of public hospitals, and yet they have been the powerhouse for so long, and the high quality multidisciplinary interprofessional placements. In fact, it was well regarded, and has always in my experience been, that you needed as a graduate to spend a year or two in a public hospital to get your skills up in all of these different areas. So I don't know what's happened to that, with the idea that you take students first year, second year, third year, fourth year, and then they come and work for you. And that's their experience, beside what they get in hospital or other placements, community placements, mental health. So I'm not surprised there's churn going on. But we have to remember that labour follows capital. Where the money is where graduates will go. And who would blame them, given the price of housing, their debts, their so on. So I think we've just got a perfect storm, and I am quite convinced the whole system will collapse before it gets better. It seems to be the political imperative these days. But we have got whole swathes of areas in rural where there are no allied health staff in public hospitals anymore. Even in urban capital cities, there are services that have reached non-viability because the staff have all left to go. As I said, labour will follow capital. And when I tell my colleagues, I haven't told them this yet, but when I tell them that that you as a early career allied health professional, first, second year, if you set up as a private business in the NDIS, you can get as much hourly rate as a band 8 C or D practicing professional in the UK. They will not believe it. They will probably get on planes and come all over here, but this is not going to solve the problem. So my plea is that we have to work together as a true intersectoral approach to this, because we cannot, every time I hear the word headhunt, I just cringe, because it is one step closer to the collapse of the system and the tiredness and dispiritedness of the staff. And I just want to say, if you're tired, if you're dispirited, come back to the public sector because we have to rebuild it. So that's what I want to say. We're all in this together, but we need to include the public hospitals in this. The directors of allied health have huge knowledge, and they're willing to work with the businesses in the NDIS as well to look at what can be done in an innovative way together. But it can't go forward while everybody is guarding their own resource and trying to protect it from what is actually another service. So I've got lived experience now in this sector in the NDIS. So I understand it more than I did. We have to come up with a win-win solution, and it's not through headhunting. It is not through trying to commit students in first year and second year into this. We need to look at new solutions, like the UK have got an apprenticeship model for allied health professionals and for allied health assistants. It's different to what we do. Health Education England is where you need to go to get your information on this, and particularly Beverly Harden, who is their lead. There's fantastic things happening over there. If more we open outside our countries, we will find some solutions. So that's all I wanted to say at the moment, is public hospitals who are, in any case, your NDIS clients will end up at some stage with contact with hospitals because of comorbidities and so on. But if there is no allied health there, what is the point of all of this? So I'm not dispirited. I'm not tired. I'm up for this. But that's what I want to see. Yeah. And I also think this is a political question. This is a very political question. And the group that excluded, and I always do this in Australia, is they never include the unions. They can open doors that professional associations can't, and so on. And I think don't ignore them as a source of assistance.
Yep. Thank you, Rosalie. I don't know if everybody's having the same issue that I was, but you were just breaking up there a little bit towards the end. But I think we captured most of that. So thanks, Rosalie, for your thoughts. Mark, I can see that you opened your mic. Did you have something that you wanted to contribute there?
Oh, I just wanted to quickly say that I agree with, for the most part, with what Rosalie was saying. Just around the NDIS, it's not quite as rosy as what that suggestion was. And yeah, I totally agree that we need to be looking at the public system as well. Absolutely. That's a little more complicated, but I can tell you here in SARRAH, we have had the public system involved, and it absolutely involves the public system. We need to have a completely healthy allied health system across the board. Public, private, everything. So I can tell you that that is absolutely the focus that we have, and that's what we're striving for, and we've got everybody on the table so that we can make that happen.
So thanks, Mark, and certainly both from the comments and from our from what we've heard from our speakers today, what we are looking for is an intersectoral approach. So the focus of our chat today was, one eye on the disability sector, but certainly looking at that issue across the board. And from what we've heard today, our single most imperative issue is that workforce shortage, and that is hitting everybody, and it's hitting hard. And so what I'd like to do now is just try and focus a little bit, because we've only got 15, 20 minutes left to have a bit of a discussion about this. And so if I could just pick up on one or two of these themes just to try and focus. So, we did warn you we weren't going to get to everything today, but what I thought would be useful to talk about, because it has cropped up several times, is that issue around undergraduate student selection, creating pathways from school into allied health degrees, and what those stepping stones might look like. And yeah, so that might be to start with. Is everybody okay to take that line? And is there something else that's burning that somebody really, really wants us to address? So yes, please, yep. Robin.
Robin, yes. Robin Adams. I show up as Healy. Thank you. Brilliant discussion. Problems familiar. Look, initiatives from the Commonwealth have focused so long on school to uni and supporting rural placements. I still would argue it's important to support uni to work placements. Funding doesn't really flow in that place, and unless we actually develop a viable way into rural practice that is supported, then we have a barrier. And you know, the Allied Health Rural Generalist Program is one step in there. It's not the only step. There are lots of ways that you could do that. But unless there's a systemic, across the board way to transition students, graduates into appropriately supported rural and remote work that does cross-sector, that does perhaps build local allied health workforce solutions, you know, like TARI are doing, a systems approach locally. So we can talk in systems at national, state and local level. TARI is saying, here's our local system and we are part of the state system and here's the next level. So let's talk about systems at all levels, but let's not buy into the Commonwealth and state stuff that has always been about students, school to there. The whole pathway needs to go, and we've really lost it at that grad to entry level. Thanks, Kath.
Thanks, Robin. Yep. So thank you. And that point isn't lost on us here at SARRAH. You know, that's the space we play in. And I guess that some of the comments that we've heard from various presenters today back up what we are seeing with regard to the Allied Health Rural Generalist program, that the pathway that we are implementing at the moment, and that is that you can put I guess my view on this is that you can put all of the supports that the pathway places around a new trainee. They're still going to get headhunted. And that's what we're finding, that, you know, you show any capacity, any initiative, any willingness to stay put, and you're going to get promoted and or headhunted. That's what we're finding so far. And so for me, fundamentally, the issue comes back to, you know, it's we're competing with each other, and there's just not enough of us to go around.
I guess that's why that local systems approach to, you know, and tying into a more state approach and federal, so that somehow we can address that issue of poaching, so we can get more collaboration. Systems, you know, if it's up to us individually in each service, yeah, we're cannibalizing each other.
Yes, yeah, that's right, because it's so tight. So, which is, I guess, why I wanted to kind of focus a little bit on, you know, on undergraduate selection. I mean, I think we are facing a crisis. You know, what we've been saying, you know, to government and to decision makers in recent times is that, you know, there's this acute on chronic issue, and thank you to those online who have helped contribute to this viewpoint. And so we've had the incremental introduction of the NDIS since 2013, which has placed this growing demand on the allied health workforce. And on top of that, in the last 2 years, obviously, we've had the COVID crisis with border closures and reduced workforce mobility, which has to have had an impact on our current situation. But this has been building for a long time. This is not a sudden, oh, you know, we can't get staff. This has been building for a long time. And there hasn't been a raft of programs and policies in place to grow the allied health workforce. You know, and I'm not talking state, federal, you know, there is a general, and in fact, I would have to acknowledge the work that the state governments have done in terms of workforce development. That's why we have a rural generalist pathway, thanks to the work that's been done by Queensland Health in this area. you know, obviously the demand is outstripping, you know, the efforts that we are making on the ground to get things happening. So there's a raft of things that have to do. Now, what SARRAH can do is look at systems and look at policies and programs and put some clear suggestions and recommendations to government to change systems to improve workforce development. Obviously, that's not an overnight fix. So this is some of what we want to achieve today. On the other end of that spectrum, we've got the Dundaloo approach, which is looking, and the Rachel Tosh approach, which is looking at local innovation and initiatives that help support local service development. So and I think it's been fantastic hearing some of the work that's happening at a local level today. And what I'd like to do is look at how we can take some of those lessons and craft it into, you know, a bunch of recommendations that we can take to government. So I'm going to open the mic at this point. Does anybody have some contribution to make, and or are we missing anything in that picture at the moment? You're on mute, Al.
I'm just going to look for hands going up.
Oh.
But if anyone wants to say something, I will throw in something while I'm looking for hands, but by all means chip in, people. The Queensland again last week announced a parliamentary inquiry that might get to the very point we're talking about, and they're looking for people to contribute. Thanks. Stephen's going to be speaking in a second, Stephen Sykes. Basically, they're talking about an inquiry that looks across the NDIS, aged care, primary health care, hospital system, and talks about the interactions between them. Now, obviously, everything we've talked about and workforce shortages comes up in that context. It's in the lead up to a federal election and a parliamentary inquiry in a hot seat like Queensland. I think that's something we're going to be interested in, and I encourage you to as well. Sorry, so I'll finish now. Stephen.
Thanks, Alan. Just by way of background, I kind of work in very small communities, generally small local government areas in rural New South Wales, and also with Aboriginal based land councils and health providers. I just wanted to talk briefly about some work we've been doing in Grenfell, which is at Weddenshire Council in New South Wales, where there's a small TAFE learning centre, and we've been working with NDIS providers to recruit local community members to work with the NDIS providers and actually to provide them training and work with TAFE in doing that. There are a lot of structural challenges with making that work. Some of them sit around very simple things like the articulation of Cert 3 into Cert 4. So you've got sometimes Aboriginal students who've done a Cert 3, they move into a Cert 4 or diploma and find that because they group the TAFE courses, they've got to redo units that they've already done. That's particularly frustrating, as well as for older people who are perhaps coming back into the workforce. They're finding that they have to do the same units again, say in the aged care certificate or a disability certificate at Cert 4 or a diploma in community services. So there are some challenges there. And then articulation into something, into say aged care training. There are some real challenges with the lack of online, competent online courses for aged care in small communities. So if you want to train people and then get them through something like aged services or a disability certificate into other allied health courses, they live locally, they develop their skills locally, they're not going to leave those communities. A lot of them are partners of farmers. They're people who might be in their 50s who are looking to do something a bit different now that, you know, that their family life has changed. And so the TAFE and their articulation into degree courses just needs to find some way of working better than it does at the moment. That's probably enough for me. I mean, there's a whole lot of other things I could talk about in terms of Aboriginal skills development, but I noticed some people say that there's not enough support for people with disability in TAFE courses. The same applies to Aboriginal. The online courses seem to be so much better than the face-to-face courses that happen in places like Bathurst or even in Sydney.
Great, thanks, Stephen. You know, apart from coming from that wonderful part of the world near where I grew up in Maringo, you make some really good points around, you know, making those Cert 3 and Cert 4 options doable for allied health assistants. But on that theme, and what was raised earlier was that issue around the tension and some of the challenges in training allied health assistants. And so somebody mentioned, you know, that issue around needing a Cert 4 in adult education and training, or, you know, various workplace-based training, whatever flavour that takes. Nerida, if you're still on, do you have, would you be able to just, because I know you and I have had a brief chat there at one point around, you know, some of the workarounds for that. Is that something you're able to speak to?
I'd be very careful.
Yes.
Because, I mean, I guess this is one of the complexities, obviously, in the vocational education system. We're very highly regulated, and it's a highly, compliance-driven system. And one of the barriers, I think, for an emerging sector like ours, and a highly, I guess, professionalised sector, as I said too, because we're also at the end where we can't get enough practitioners. How do we actually go to train and assess in TAFE? You need to undertake a Cert 4 in training and assessment, and that takes that qualification has evolved over time, and it is now quite a significant qualification for people to choose to do. Now, I can offer anybody a scholarship to do that, so please hit me up if you'd like to undertake some free training, but it doesn't mean you don't have to do the work. You've still got to prioritise that time to do that. So I think that is a systems barrier for our kind of area that's different in some other sectors, you know, like over time that we're actually working for TAFE was a really viable job option and actually often, you know, higher salaries and things. We're not in that environment now. So we do have to think cleverly about it, and there are ways, as Kath said, to organise ourselves in terms of making sure that our teacher and assessor resources are able to be put in place at the right points in the system, so we don't have to have, for example, our people doing all of the supervision or all of the assessment. There might be different ways of having that and being smarter, and I think that I was just putting the pod there about to Stephen to talk to me about ways to, because we are starting to really look at that, how we're doing that diversified, decentralized training as much as we can do online, and building the quality of that online delivery and making it connected. So, you know, actually engaging with people, but then looking at local based assessment pod times where we come out, bring people together locally and building the cohorts. Often our tricky thing, obviously, you know, people will say, oh, we've got 2 people need to be trained in Grenfell, 2 in Canowindra, couple in Cowra. You know, that's not a viable cohort. We're all working in a business model. You know, we have to demonstrate those viabilities. But I can pull together, for example, you know, an Aboriginal cohort of Aboriginal students across New South Wales coming together virtually as a cohort, and then doing their skills training, for example, with other groups coming together who also have to do that unit of competency, for example. So they come to maybe Cowra or Orange or Bathurst or something together as a group over a weekend or a couple of days and do that intensive skills assessment training. We can bring our teachers, our assessors into that. That makes sense. So that's kind of the model that we're working towards, I think, is having that flexibility, but that does, you know, rely on us working together. The other piece is getting involvement in the quality of the training and keeping that up to date. So obviously anybody who's teaching in our system for a long time, you know, we know how quickly this stuff is moving. Also, allied health is so broad and deep. So, you know, it's not just enough to have a speech pathologist. We have to have a speech pathologist who either works in early intervention kids or a speechy who works in adults and dysphagia and aged care. You know, we're cutting those, you know, cutting that pie in different ways. And that really is then about, we can't expect to have people with Cert 4 qualifications across all of those different iterations, but we want to talk to you. We want to engage you in our training. How do we do that to enhance our training product? You know, and then how do we also involve you in development of our assessment tools and things like that? And then how do we ensure students are getting those opportunities for placements in those different kinds of ways? And also a setup to think about that ongoing professional development. So how do we develop skill sets that we can deliver that are very highly contextualized, for a particular part of the industry?
Yep. Thanks, Nerida. It kind of, my interest in this is obviously because we have some funding at the moment to implement an allied health assistant program to increase uptake of allied health assistant roles in non-government settings. There are going to be some systemic challenges that we're going to face as we implement this project. But it also presents a fantastic opportunity to actually really identify where the system barriers are and try and get them fixed. So I saw Rachel's comments, and Rachel's just come off mic, so off mute. So Rachel, would you like to contribute?
Thanks, Kath. So just with the AHA stuff, I think that one of the key issues is that we keep looking at the training side of things. And yes, those barriers are significant, but the reality is the private sector would solve those themselves if the financial model was viable to create an allied health workforce working as part of the allied health workforce as a whole. That is not there in the NDIS. The way that it's funded and the hourly rate structure does not work. Prior to the NDIS, we had allied health assistants in our business seeing private pay clients. We were charging $90 an hour for those services. This is pre-2017. The level 2 AHA funded rate currently, I think, is $86.43 or something like that. That is not enough to be even break even, much less make a profit. So until those elements are addressed, we will not, solving the training component doesn't matter, because it doesn't matter how many AHAs you train. If there's no jobs for them in the NDIS sector, which is the private sector, that is private practices. If there's no jobs for them, what's the use of qualifying them? We've had probably about 20 AHA students come through high school traineeships, as well as through high school based, sorry, I don't know the right term for this because I don't work in the vet sector, and also through mature age students that are going through the TAFE system separately. And we have no jobs for them, because there's no way that we can make that work under the current financial constraints of the current funding models. So that's the piece that I feel needs to be addressed, because you then have enough draw in the system where, let's be honest, private practice owners, they want to solve this stuff. We are talking to each other all the time about how can we do this to help the 300 clients on our waiting list at the moment. We're looking for ways to do that. We are already looking for ways that we can creatively do that. But when the funding isn't there, the solutions won't be found.
Yeah, thanks, Rachel. They're really important points, and stuff that we at SARRAH will certainly be picking up and running with. And I guess the challenge, one of the challenges we're facing at the moment is around, so we've seen this emerging issue in the disability sector. What we want to do is avoid similar situations arising in the aged care sector. Now, I just wanted to throw quickly to Jeremy. and Sabina, I've just seen you raise your hand, but just give me one moment, to speak to his model where he employs an allied health assistant in an aged care facility. So Jeremy, thank you.
Yeah, we were really lucky to and privileged to be working with the PHN in our area and Murrumbidgee Local Health District to produce a program where we have private public mix, where we have private physios do work in public hospitals, set up care plans for allied health assistants to carry out, and that included aspects of aged care and multi-purpose services. And so that was a great mix for us because it led to a critical mass of work where it funded enough that we could then extend our services out to some of these more rural regional places that otherwise wouldn't get access to the services. That program's been challenged a lot with COVID lately, but it's still out there, and we'll still be working towards it to continue to build on that. But yeah, moving forward, we're looking at increasing the amount of our allied health assistants role in aged care, and in the similar model of trying to set up care plans and have the allied health assistant carry them out.
Fantastic, thanks, Jeremy. And you know, so I would add to that by just saying that you know, we need to think about the allied health service as encompassing both allied health professionals and assistants. And from our perspective, it shouldn't matter who's delivering the service. It's still the allied health professional who is responsible for the safety and quality of that service, who is responsible for undertaking the assessments, determining the appropriateness of services being delivered by allied health assistants. And so there shouldn't be a price differential between an allied health professional and an allied health assistant delivering. It's all one service. So that's something that I'd invite comment on in the chat function and face to face. But Sabina, going to you.
Yeah, thanks. I just wanted to comment about the work opportunities. I think any employment opportunities for Indigenous allied health assistants are greatly welcome. I don't see it as a negative that people are training ahead of employment opportunities, but there is a demand in Aboriginal community controlled health services and the smaller rural and remote commission services, and in the community aged care services for allied health assistants. So I think in your messaging to the Commonwealth, I think it's really important to support training, access to training for those people, because it's not easy, because they're far away from the training and they're best placed to work with the allied health professionals to keep those services going. And we've seen models like in Tasmania, where in the private sector it works quite well.
Fantastic, thanks Sabina. Now it is, how are we going for time? I just wanted to, was there anybody else who had something burning to say at this point? Have we, you know, is there anybody feeling like they haven't had an opportunity to speak? Leonie.
Yes, Kath, sorry, it's
Hello.
Leonie here. Hello, colleagues. I'd just like to say that in discussions I've had recently with key stakeholders in the aged care sector, where we've got no traction whatsoever to try to get funding to treat people in the aged home and disability sector for oral health care. And at the moment that's being done by carers, and it's not a dentally led care, unfortunately, with poor or no referral pathways. So just to raise the dental hat, particularly in the aged home and disability sectors, we're still trying to lobby for the senior dental benefit scheme. Thank you.
No worries, thanks Leonie. Good plug there. All right, so I'm now going to try and wrap up. Yeah, so thank you for, I mean, firstly, thank you all for what has been a really stimulating discussion and a very valuable discussion. And we will take everything that's been said and everything that's been put into the chat. And those that have been participating today, we will circulate a document, won't we, Al? We'll do that, won't we? Yep.
We will indeed.
Yeah. So I guess for me, it was kind of galvanizing into local innovation and the importance of having those local community-led initiatives where people are going to have the most impact, actually. And SARRAH is here to support you through having those conversations together. If there's anything that SARRAH can do to facilitate some of these discussions happening, because we can connect with some of these people who have been doing various models of innovation, and so we'd be very happy to continue to assist you to have these local conversations. But then at the systems end, our job is about talking to governments of various sorts to ensure that we've got appropriate policies and programs in place that support this work. So what we're hearing there is, firstly, that it does need to be cross-sectoral. We need to involve everybody who is providing services to a particular community to ensure that we are capturing all of the capacity and the potential. We need to do things like reviewing the training pathways and reviewing funding models to be able to support those locally generated solutions. So again, this is where you talking to us is really helpful, so that when you are trying to resolve some of these issues locally and you're coming up against these barriers, if you can bring those issues to us, and we will chew various people's ear about getting things changed. So that is hopefully what we are going to be able to pull together, from the discussion today. So it doesn't end here. There will be some ongoing correspondence, and I invite you all to reach out to us through the sarrah@sarrah.org.au mailbox, and continue to generate some fantastic solutions. But I'm hearing you. I'm hearing the challenges at the moment, and that's one of the key messages that we need to be sending, is that this is a crisis, and people are tired and they are falling over. I'm going to pause there and ask if Ed would like to have a few final words. Ed, you may be on mute. You may even have stepped away momentarily. Okay, all right. So
that was a good Ed impression. Anyway.
Oh,
Sorry,
here he
Kath,
is. He's back.
I've just had someone calling me. I had to palm them off.
That's okay.
But yes, thank you so much for everyone for your contributions. I think it's been a really useful discussion, a start to a discussion, I think. We have acknowledged a lot of old problems that we've got with providing disability supports that predate NDIS, and some problems that are continuing to rear their ugly head. Like the funding models and the viability of funding especially in more remote areas, and the workforce shortages and maldistribution as well. I think really importantly, those barriers to innovation that were mentioned a few times, and running on goodwill, which seems to be something that's not particular to disability, but happens a lot in this sector as well. We also acknowledged new problems like training pipelines, and I think touched on the level of clinical expertise that's out there in disability. I think Rosalie mentioned that the workforce follows the capital, and unfortunately that means that we've got a whole lot of people trained up to be really good, perhaps primary health clinicians, but not necessarily disability focused clinicians, which is presenting clinical quality issues as well. And a lot of, say, entry-level clinical skills that are politically acceptable, but not socially acceptable, I don't think. And potentially we may succeed despite the NDIS rather than because of it. But I think there are some great solutions that we're starting to talk about here, especially in terms of pathways. I know that Paul has mentioned in the chat from IHA about the IHA academies that are training up co-workers to be able to work on more place-based solutions for these problems, and training pipelines that Sarah's working on as well, and that people are working on at a local community and practice level as well. So while we are facing a raft of difficulties, as we always do in allied health, I think there are some promising discussions to continue having in the future. And I'd like to also invite you after a short break to come back at 12 o'clock to our AGM. We'd love to have you there to review what's been happening in the last year at SARRAH, and welcome the board for the new year. So please consider coming along to that. We'd love to see you there as well. Thanks, Kath.
Terrific. So thank you, Ed. That draws to a conclusion today's seminar. Thank you very much for everybody's participation, and we'll be in touch very soon. Thanks, everybody.